Hello and welcome. Today we're going to be breaking down a condition you might hear about during pregnancy, low platelets. Now I know it sounds a little technical, but we're going to make it super clear what it is, why it happens, and how it's managed. Let's dive right in.
So, here's our game plan. We'll start with the absolute basics. What are we even talking about? Then we'll look at the #1 most common cause, and then talk about when doctors look for something more serious. And we'll wrap it all up by covering how it's managed and what it all means for planning a safe delivery.
All right, first up, what exactly are low platelets? Let's build a really solid foundation so everything else makes sense.
Okay, so the official medical term is thrombocytopenia. It's really just a fancy way of saying your platelet count is lower than normal during pregnancy. But here's the first thing you need to know. This is not some rare, unheard of thing. It's actually the second most common blood-related issue pregnant people face, right behind anemia. So doctors and midwives see this all the time.
And this right here? This is the magic number. When your doctor gets your blood work back, if your platelet count is below 150,000 per microliter, that's just a tiny drop of blood, that's the official cutoff. That's when they say, okay, we're looking at thrombocytopenia.
But, and this is a big but, not all low counts are created equal. Doctors actually break it down by severity. As you can see, anything between 100,000 and that 149,000 mark is considered mild. And honestly, this is where the vast majority of cases fall, which is really reassuring.
Okay, so if you do have low platelets, what's the most likely reason? Let's play detective and look into the usual suspect.
And wow, this chart really tells the whole story, doesn't it? Just look at that huge slice, 75%. 3/4 of all cases are caused by something called gestational thrombocytopenia. This is, by far, the most common reason, and as you're about to see, it's also the least worrisome. That is fantastic news. This side-by-side comparison is so helpful. On the left, you've got the really common one, gestational thrombocytopenia. It shows up late in pregnancy, the platelet count is usually just mildly low, and get this, it goes away all by itself after the baby is born. No treatment needed. On the right, you have ITP. It's a totally different beast. It's an autoimmune issue, it can be more serious, and it might need treatment. But the key takeaway here is that most people are firmly in that first, much calmer category on the left. Now, even though most cases are pretty straightforward, it's absolutely vital for doctors to rule out anything more serious. So let's talk about the red flags they're trained to look for. Okay, so a huge red flag goes up if the platelet count drops below 100,000, especially if there are other symptoms going on. This is when your care team immediately starts to investigate for a serious condition called HELP syndrome, which is actually a complication of preeclampsia.
The name HELP is actually an acronym. The H stands for hemolysis, which is a breakdown of red blood cells. The EL stands for elevated liver enzymes, and the LP, of course, is for low platelets. It's a very severe form of preeclampsia, and when it comes to managing it, there's really only one answer: delivering the baby.
So, we know that the most common type doesn't need any treatment. But what happens if it turns out to be ITP? Well, there's a very clear action plan for that. Let's take a look.
For ITP, the treatment plan is kind of like a ladder. You start on the first rung. The first-line therapy is usually corticosteroids, like prednisone, to calm down the immune system. If a faster response is needed, say right before delivery, doctors can use IVIG. And then, only as a very rare last resort for severe cases that don't respond to anything else, they might consider a splenectomy, which is removing the spleen, since that's where the platelets are often being destroyed.
Now, this is such a critical point. The goal of treatment isn't necessarily to get the platelet count back to normal. It's to get it to a safe number for the specific situation. You can see the goalposts move, right? For a patient with no symptoms, just being over 30,000 might be fine. But for delivery, the team wants to see that number above 50,000. And if an epidural is part of the plan, the target is even higher, usually over 80,000.
Which brings us to our final and maybe most important topic. What does all of this mean for the big day? Let's talk about what you can expect when it's time to plan for a safe delivery.
This is it. This is probably the #1 question on everyone's mind, and for good reason. It's a huge part of planning for pain management. So, is an epidural still on the table?
Well, the answer usually boils down to this number, 80,000. Most hospitals and anesthesiologists use this as a general cutoff. If the platelet count is lower than that, they often won't do regional anesthesia, like an epidural or a spinal block. And it's not arbitrary. It's a critical safety measure to prevent a very rare but serious risk of bleeding around the spinal cord.
So, besides the epidural question, what else is the team thinking about? Well, a few key things. First, a vaginal delivery is almost always preferred if it's safe. Second, having low platelets alone is not a reason to do a C-section. Third, platelet transfusions are used pretty sparingly, only if the count is super low and there's active bleeding or delivery is about to happen. And finally, the team will check the baby's platelet count after birth, especially if the cause was ITP.
So let's just quickly recap the big ideas. Number 1, low platelets are super common and usually totally harmless. Number 2, it's always something to monitor just to make sure it's not a more serious issue like ITP or HELP. 3, management and delivery plans are all based on hitting specific, safe platelet targets. And finally, and most importantly, your healthcare team has one goal, a safe delivery for you and your baby, and they have very clear, well-established plans to make that happen.
And that brings us to the end. You know, understanding your health is the first step, but being an active participant in your care is the next. So we'll leave you with this question to think about. Now that you have this information, what questions will you ask your healthcare team?